Right now is a very exciting time in the field of multiple myeloma. It is, we're in the midst of I think, a period of really, really fast therapeutic development. The myeloma field over the years has had more than its share of advances compared to many other types of cancer, and we have many FDA-approved options. The place where we still struggle is after the first several lines of therapy. And while we fully expect frontline therapy to result in a response, and the majority of patients get into remission, and now with best available therapies, half to slightly more than that will even get into like an MRD negative, minimal residual disease negative, deep remission. And that also sometimes happens with subsequent lines of therapy, though it's less likely to. And by the time a person has had 3 lines of therapy or more, and they're resistant to at least 3 different classes of drugs, the main 3, the proteasome inhibitors, the immunomodulatory drugs, and the CD38 antibodies, anti-CD38 antibodies. After that, therapy becomes a bit less effective overall. And it's a pretty common scenario for patients to start going through therapies fairly quickly. There are a lot of options for treatment beyond 3rd line, but the response rates, the single agent response rates for the approved agents in that space are in the range of 15 to 35%. And durable responses, complete responses, become a lot less common. And so this is a space where we really need new treatments to sort of realize the same kind of success that we do with earlier lines. Immune therapies are sort of moving into that space, and I think are poised to serve that role. We've been hearing about CAR T cells for a few years now, with really amazing response rates. And the first one was approved this last year. And we heard a lot of great data at the American Society of Hematology meeting in Atlanta just this month. But there have been some toxicity issues, specifically neurologic events, and also a high rate of something called cytokine release syndrome. And then there's been accessibility issues, both with the commercial product and on clinical trials, just in terms of the number of patients who want access to that therapy, who actually are able to get it. So the other really promising class in that sort of space is bispecific antibodies. What a bispecific antibody is, in contrast to a typical monoclonal antibody, which has 2 binding points for a single specific target, bispecific antibodies simultaneously bind 2 different targets. And what's usually the case, the bispecifics that are being developed in multiple myeloma, they, on the one hand, bind myeloma cells, and then on the other, find an immune cell and bring the immune cell basically in contact with the myeloma and facilitate cellular killing of the myeloma. So it's definitely an enhanced anti-myeloma mechanism compared to a typical monoclonal antibody.